I'm very privileged and feel very humbled to speak to Joan and Linda and the group. This is a charity and an NGO that punches far above its weight and has done for very many years and makes such a positive impact and really does contribute to progress where sometimes it can seem hopeless and difficult. Today I want to talk a little bit about the new NICE guideline as has been flagged. And I won't be talking so much about the content of the guideline or its implementation per se. And you will hear a little bit more about that from Leslie Edgar a little bit later. But what I do want to talk about are some of the myths, some of the misperceptions. We live in an age of misinformation, and we I want to double check my time. We live in a misinformation age, essentially. Fake news, alternative facts, alternative truths. And some of it is entirely innocent. It's just a world of noisy media. People often get things wrong. Things can travel the world very quickly. Misperceptions and stereotypes can be undetected, and we can end up with all sorts of misapprehensions. I think that has been the experience for many years and many decades, in fact, in the world of ME and CFS. And then the new NICE guideline is a step forward in that regard, but not unaffected by the misinformation problem. So I'm going to be referring to the guideline per se, and you can access all the material very freely online. And I'm going to talk a little bit about how we agree and disagree with each other. And we can, there are different levels of evidence that academics talk about in terms of how we actually can sort of reach a common ground. And sometimes you see people defending a position based purely on their impulse or their intuition, or indeed maybe their insult, rather than on empirical evidence. You can study that a little bit later. There are lots of interesting details there. I'm going to talk to you about 8 separate myths. The first myth is essentially that CBT and GET are quote-unquote evidence-based treatments for ME CFS. So we're referring here to cognitive behaviour therapy and graded exercise therapy, and this is the classic combination. I think it was described a little bit earlier as exercise and optimism. I mean, it's a fantastic way of putting it. That approach to treating ME CFS has sort of been around for a very long time, and I think we're all somewhat aware of the shortcomings. Nonetheless, after the NICE guideline was published, we still had, it wasn't as though everybody just stopped talking about CBT and GET. In fact, that momentum carried on, and people continued to talk about these treatments as though they were evidence-based. Now, I'm going to give you some little clips. So in the Journal of General Internal Medicine in February 2022, that's several months after the guideline was published in November 2021, we had authors simply in an article that was more or less entitled Evidence-Based Treatments for ME CFS. They say something like, the main evidence-based treatments are cognitive behaviour therapy and graded exercise therapy. So simply stating as fact something that is highly questionable and indeed has been explained to be inaccurate. And the Royal College of Physicians published a statement on the website the day the guideline was published, or the day in advance of the guideline being published. CBT remains a valuable treatment for alleviating symptoms. It remains, even though NICE have identified that it doesn't work. An expert, quote unquote, for the Science Media Centre, in light of the publication of the new guideline, the NICE guidelines for CFS-ME are at odds with the evidence, according to this expert. And evidence has shown that these treatments reduce fatigue, whatever that has to do, and improve functioning. So there is an inclination simply to state the opposite, or to state the myth. In a letter to the Daily Mail, now I have a wide range of sources here. Some of the experts, quote unquote, write letters to the Daily Mail, and they wrote to say scientific trials of graded exercise therapy show it is effective and safe, when in fact the opposite is the case. All right, so these are myths, and the NICE guideline has clarified that those two treatments, as has been mentioned, are no longer to be used for ME CFS. Let me just give you a flavour of the NICE guideline in a sense. The NICE guideline recommends that a multidisciplinary team be involved and that a specific personalised care plan be developed in consultation with these specialists that include rheumatology, rehabilitation medicine, endocrinology, infectious disease medicine, neurology and so on. And the guideline states, this is an extract from the guideline, a clip from the guideline, that those specialists may be supported by a physiotherapist or a psychologist, but also then, by implication, maybe not. So the emphasis in the NICE guideline is not on exercise and optimism, it is on all of these specialist areas of medicine. And then there's this very detailed sort of step-by-step plan, personalised care and support plan methodology. And all of these types of things need to be done. And this is what the NICE guideline tells the world should happen. Nothing to do with GET and CBT in this care plan. Cognitive behaviour therapy is to be recommended simply as a psychotherapy for people who need psychotherapy for emotional support, and graded exercise therapy is not to be used at all. So the NICE guideline couldn't be clearer, and so for academics or physicians to talk about the only evidence-based treatments are cognitive behaviour therapy and graded exercise therapy, that's simply a non-fact, but it's being presented and published in different venues in spite of the detailed work that NICE have done to debunk it. But I will piece together some of that. In order to explain one myth, you have to talk about other myths. So a second myth that you often see, and this is a bit more subtle. So this is the myth that says that the new NICE guideline is different to the old NICE guideline, and that's irrational because evidence cannot just change. All right, that's a line of argument you see. And where do you see it? Well, you see it, for example, in the British Medical Journal, the BMJ, in the news section, which is a news reporting section. It's not a letter to the Daily Mail. This is somebody who has been sent out in order to report the news. And they have reported that when the draft guideline was published, that it raised questions about how the evidence could have shifted so substantially. And the journalist goes on to say, it is unclear, however, how the evidence became unsupportive. Okay, so that's a line being taken by a journalist in the BMJ, presumably somebody who has interviewed all sorts of vested interests with regard to what to say. But we can look at how the evidence became unsupportive. The implication is that it's a mystery that the evidence somehow changed from one moment to another, as though science isn't a process of continuous evidence gathering, and as if the scientific method doesn't require us to change our position when the evidence becomes clearer. In the 2007 guideline, this is a graph showing the number of studies the reviewers consulted in order to draft the guideline with respect to CBT and GET. And even though I haven't presented the data here, when I do, you can barely see a difference. Because the answer is 4 studies of CBT were consulted and 5 studies of graded exercise therapy were consulted in order to draft the guideline. Not only that, but there's a whole saga around this about the people who did the study, they did the review. They published it in a journal first and said the studies were terrible. But when they published it under the NICE exercise, the people involved decided to take the critique of methodology out of the report. So they simply relied on 9 studies in total, 4 in one of one kind and 5 of the other. But in the new guideline, which was originally published in 2020 in draft form, the NICE reviewers examined 172 CBT research findings and 64 GET research findings. And from those reviews, they concluded that the studies were very, very weak in many, many cases. But from having looked at these 230-odd studies, they concluded there was no evidence base to support these treatments. That is how the evidence became unsupportive. It's because there was a sea change in the amount of evidence that was available. It wasn't that the evidence changed. It was just that the old guidelines were based on such little information that the evidence actually wasn't even there in most cases or in most senses of the term. Not only that, and this is where I would get a bit directly critical about journalistic standards. Not only that, but the guidelines were published in draft form months ahead of time, a year ahead of time, put out for consultation. And a 356-page document was posted on the NICE website explaining how the evidence became unsupportive. So for someone to write an article in the BMJ saying that it was unclear to them how it became unsupportive, all that means is they didn't read this document. It was freely available, it was in the public domain, it was part of a consultation exercise. You were supposed to consult it before commenting. So that's a very clear myth. These treatments are not evidence-based, and the evidence didn't just become unsupportive mysteriously. It was a very clear scientific picture and scientific progression. Myth number 3. The NICE processes, okay, they did that, but they did it in a way that was lacking in transparency and insufficiently consultative. So there were many sort of quotes to this effect that NICE operated in secret, and the doctors and the journalists in the BMJ who said it was a mystery to them what happened, they were inclined to say this is because NICE, they can't really be trusted because they operate in secret and nobody knows who they are or what they're doing. In reality, that is mythical because NICE published not only the 356-page evidence review of non-pharmacological treatments, they in fact published a total of 2,733 pages of documentation as part of the consultation process. So there was ample information. In fact, there was almost too much information available rather than insufficient amounts of that information. And the consultation exercise dragged on and was extended in order to allow for a huge number of submissions to be made. So it couldn't have been more consultative. Not only that, as we might all remember, they delayed the publication of the final version in order to hold a face-to-face meeting with representative groups of agencies and other associations who wanted to talk more about it. So they actually went out of their way to be consultative and informative about this process. There was no lack of transparency at all. Myth 4 and 5, I'm going to give you 2 for the price of 1 here. The NICE review was driven by patient advocates, and we all know that they can't be trusted, at the expense of scientific rigour. So there's this kind of juxtaposition of, patients are not scientific. And the additional myth there, the defenders of the old guideline are simply standing up for science. So there's this narrative, this power narrative, and I am a psychologist, so forgive me for considering the psychological dimensions of this, but there's this power narrative that the patients should know their place because we are the scientists and we know better, even though the guideline was very scientifically informed. The NICE Guideline Committee, I don't know you can't read all the text, but the people on the left there are the non-lay members. The paediatric consultants, the infectious disease consultants, the senior physiotherapists, the research nurses, the clinical psychology senior lecturers, the dietitian specialists, and so on. There are many, many people. People on the right are the lay members. So the group was the same as any and many other NICE groups. It was predominantly driven by clinical experts in their respective fields. It was not dominated by lay members. And as we saw, it was not dominated by anecdotal opinion either, because there was hundreds of pages of studies reviewed and all that explanation was offered. So this idea that there were scientific, kind of anti-scientific people driving NICE to change their guidelines and that the people who are critical of that are standing up for science against the activists, that's a misrepresentation. That's another myth. And incidentally, I have to draw attention to some of the stakeholder submissions as part of the consultation exercise. Thousands of submissions were received, many of them from very esoteric organisations promoting odd therapies, but some of them also from mainstream organisations like the Royal College of Physicians, who, as part of their submission, because somebody got in there to say to the RCP, you better complain about these guidelines because we don't like them. And part of the submission made by the Royal College of Physicians to NICE as part of the consultation said things like they were annoyed or they were disapproving of the fact that certain therapies were removed, not just CBT and GET, but also neurolinguistic processing and the lightning process. Now, neurolinguistic processing or neurolinguistic programming is an out-and-out pseudoscience. And the lightning process is a pseudoscientific treatment because it involves NLP. This is not mainstream scientific or clinical care. This is a very controversial, pseudoscientific, some would say almost cultish practice, where people go to hotels at the weekend, spend thousands of pounds listening to a guru telling them to evacuate the disease from their body. And this is supposed to be the way in which you cure these things. Now, for the Royal College of Physicians to be speaking up on behalf of the lightning process as part of a scattergun approach to criticising NICE for ditching things that have already been done before and for proposing change, that doesn't, to me, suggest that these folks are standing up for science at all. So I think it is actually an abuse of privilege to criticise others for standing against science when you yourself, as an academic or a scientist or a clinician, are supposed to be a scientific practitioner, and that you're simultaneously standing up for things like the lightning process as part of your, as I say, scattergun approach to criticising. Here's another thing. The delay to the publication of the NICE guideline was to facilitate, among other things, a roundtable meeting with representatives of different organisations, such as the Royal Colleges and some NHS bodies as well. And that roundtable, the minutes of the roundtable were published on the NICE website. And one sometimes gets the impression that a lot of the correspondences received and a lot of the discussions had were conducted without the participants being aware that it was all going to be published afterwards. So the minutes of this roundtable meeting were published afterwards, and it was pointed out in relation to CBT and GET, two things. The minutes said that the group of representatives making representations to NICE, expressing concern about the NICE guideline, wished to discuss the potential of the guidance on the commissioning and delivery of services. And that was written to GET. And in relation to cognitive behaviour therapy, as the recommendation or the pointing out by NICE that CBT doesn't work was also associated with concerns that this may have a negative impact on the commissioning of services. So the concerns raised at that meeting wasn't that this was unscientific. The concerns raised were that what are we going to do with all our CBT providers if CBT is not supposed to be provided? The commissioning of services was more, it appeared, to be a priority than the science. So for folks to come out and say we're standing up for science, when in private, in the room, in the meeting, they're saying they're worried about commissioning of services, I think there's an inconsistency there. What we're seeing in this sphere is what we call a paradigm shift. So when we call in the philosophy of science or in epistemology, a paradigm shift. So this is the idea that everything we used to think was correct actually needs to be adjusted. We need to update that, and we need to shift our paradigm, and this is constantly associated with resistance. It's not as though scientifically minded people simply change their minds in a moment. There is often a period of contemplation and resistance as the facts become absorbed. Myth number 6. Getting rid of CBT is old-fashioned dualism. This is for the philosophers out there. Treating the mental as separate from the physical. So sometimes people say that, and I'm a psychologist and a lot of my colleagues are psychiatrists and mental health professionals and so on. People say it's important that we look at mental health and it's important we don't stigmatise or marginalise mental health. That's correct. But dualism is a very specific philosophical position saying that, there exists a separate realm of entity called the mental, which is unconnected to the physical. And so this idea that criticising cognitive behaviour therapy makes you a dualist is an attempt to try to discredit people who promote new practices and criticise the old ones. And you see this dualistic thinking. So you have these people quoted in the media talking about dualistic thinking, that NICE are guilty of this. So NICE's philosophy, their position on epistemology is being criticised. But in reality, what the NICE guideline says is not that CBT is a bad thing and that mental health doesn't exist. What NICE are saying is that CBT doesn't cure ME CFS, which is a different proposition. If you're going to talk philosophy and epistemology, you should include logic. So the idea that that the claim that cognitive behavior therapy can eliminate post-exertional malaise is a very specific hypothesis that has been demonstrated to be false. And simply talking around the issue that mental health is important doesn't get you off the hook if you're claiming that CBT should be used as a frontline treatment for ME CFS. And it is misleading to say that the NICE guideline group, or those of us who criticise the old treatments, are somehow against psychotherapy. That's completely incorrect. Psychotherapy is very important, and many people with chronic illnesses and lifelong illnesses and pain, they can benefit from psychotherapy as a way of navigating and of dealing with and processing the pain of their existence, their anguish as a survivor. But that doesn't mean, if you have a broken leg, and you have significant pain, perhaps some mindfulness will help you, tolerate that pain in the moment, but it won't repair the bone in your leg that is broken. So just because psychotherapy or psychotherapeutic interventions have benefits doesn't mean you have to present them as cures for a physical disease. That is a completely different proposition. And the final two myths then, because another two for the price of one. One is, and this is a subtlety, and I should have said at the outset, I'm going to refer to suicide as part of my talk. So I don't want to just throw it in there in a sentence. I want you to be aware that it's coming. Myth 7 and myth 8 is that you cannot evaluate ME CFS using objective measures. Because sometimes the point is made that much of the research has demonstrated that CBT and GET don't work, but that research has used objective measures. And you can't measure outcomes objectively in ME CFS. And therefore, the NICE is wrong in the way in which it's done its business. It has attempted to do something that shouldn't be done. Just to expand the point, NICE, it is claimed by some of the critics, some of the proponents of the old treatments and critics of the new ones, that NICE misapplied the so-called grade system for evaluating treatments, that behavioural therapies are not the same as physical therapies and so should be judged by different standards. That's the general argument. That came up in lots of different places. It came up in a guest editorial in the BMJ. Did you know that the BMJ publishes guest editorials that are not peer-reviewed? And so if the editor just likes you, you can be asked to write something. And people were asked to write about how terrible the new guidelines were. And they said, among other things, that the grade system was applied, but it shouldn't have been applied because that's for physical therapies. And you can't look at ME CFS using objective measures. You have to use subjective ones. Not only do people write letters to the newspapers, they sometimes pop up, as they say, in the comments section on the articles. So in the Times, someone called Michael S. Talked about, objected to comments being made in the media about the importance of the new guidelines by pointing out that how are we supposed to measure the success of a therapy if not by self-report, by patient self-report? There is no other measure of impact of this condition. So the claim was made that there's no way of measuring how severe ME or CFS is except by asking people to tell you how severe it is. So this simultaneously criticises the guideline, but also demeans patients by saying that you don't have any physical symptom to exhibit. It's only what you say. It's only what you claim. Subjective measures are the only way we have of knowing you have ME CFS. Okay, so the point I would make about this is that of course that's wrong. Of course that's ridiculous. But it is a myth that is trotted out again and again and again. But many research studies have used objective measures of outcomes in ME CFS. In fact, many of the people who criticised the new NICE guidelines were associated with the infamous PACE trial, which talked about CBT in GET, and they used objective measures. Now, it happens to be the case they took them out when they discovered that it didn't work, and they relied only on the self-report from publishing their papers. But the data are there. And there are many, many other studies that use objective measures, such as physical fitness tests, endurance tests, actometer data, school attendance and work attendance. and disability costs. The famous PACE trial, which is the biggest trial that they keep talking about, proved CBT to work. It only proved that CBT was associated with better questionnaire responses at the end of the trial, although even that is disputed by the statisticians who have re-examined the data. But the patients who were supposedly cured by this treatment, none of them went back to work at the end of the trial. It didn't change their lives in an objective way. It only changed what they might have said on questionnaires. And the disability costs associated with disability welfare payments for the group that were supposed to have been cured by this intervention actually went up after the intervention's success rather than down. So those people were actually sicker at the end of the trial rather than before, even though they were told that they had actually been cured by the treatment. So the objective measures are there and they are studied. And we have significant data on a strong association between severity of ME CFS and suicide. It's a real outcome, and there's not little more objective than that, and I don't wish to be in any way facetious. You are significantly more likely to be in a suicide category if you are housebound with ME CFS, and that's hard data. That's not questionnaire inquiry. There is a point of detail on this slide of data. If you are bedridden with ME CFS, you're actually less likely to take your own life. But of course, we all know the reason why that is, because you simply can't. You do not have the physical capacity to do so. So there is a very, very firm evidence base for the impact of ME CFS on people's lives, and it uses objective evidence. And the claim that there is no objective way to measure the impact of this condition, it's not just a non-fact, it's actually an offensive statement. It's an insult to people who have this illness. So the myths that we're talking about, the NICE guidelines are to be welcomed precisely because they cut through the noise, they cut through the stereotypes, they cut through the misrepresentations and the faulty logic at times. And they have a laser-like focus on evidence-based treatments and things that can and cannot be said to be evidence-based. And the NICE guidelines don't offer a magic bullet. They don't offer an instant cure for ME CFS, but they do offer a way of maximising the quality of life of people who have this terrible condition. There is no point pretending you can cure something when you can't, but there is every point in pursuing the evidence-based ways in which you can improve people's lives and encourage ongoing research into other interventions that might one day make the condition history. There are some other myths that I didn't cover, but I thought I'd draw your attention to. One revolves around NICE's definition of ME CFS. They say that NICE created a new definition. They didn't. They used an old definition. It's just not the same definition that other people use, but it's the same definition that many other people use, but it's not new, it's old. That NICE downplayed the importance of fatigue, that NICE prioritised qualitative surveys over quantitative studies. That's not the case. That's clearly not the case. NICE prioritised 230 quantitative studies of CBT and GET, for example. NICE misrepresented what GET actually is, which is a nice bit of reverse psychology, because what really happened is that the critics are trying to redefine GET after the fact, so it is they who are misrepresenting what GET is. Saying there is no cure amounts to therapeutic nihilism, and so it must be wrong. Talk about a non sequitur if you're going to get into Latinisms. Just because something cannot be cured doesn't mean that it is factually wrong, because it's pessimistic. The conditions we're talking about here, there is no cure. Some people spontaneously recover, but very small numbers. There is no known cure for ME CFS. Just because that is a fact doesn't mean, and just because that's kind of sad news doesn't mean it's wrong. So simply complaining about that is another myth. And the final one I think you'll like, quote unquote, I cured myself from ME CFS using positive thinking, therefore you can too. There's a couple of people out there, and by a couple I mean one in particular, who frequently walks up to microphones in TV and radio studios and says that, and uses their position as a medical doctor to sort of convey an authority behind it, even though their area of medicine has nothing to do with this. But that is another myth, okay? That is another thing that perhaps we can talk about at another time. Why the myths persist, I will simply try to offer an opinion on this more than anything. Partly, certainly, is to do with establishment. There is an establishment of figures out there who are seen as senior in this area. They're vastly outnumbered by others, but because it's a bit of a niche in medicine, their voices seem to have sway. And there is, I suppose, a discomfort with the fact that NICE operates an independent process. So the very independence of NICE is threatening to some folks who feel that their opinion should actually count more than what NICE's evidence review has to say. There is the real issue of what we refer to as entanglement. People often discuss entanglement in medicine in relation to, for example, the financial support of pharmaceutical companies and the influence on doctors. But there are other forms of entanglement, such as the heavy investment of time and effort and resources into things like CBT services for ME CFS. The new guideline says you can't do that anymore, or you shouldn't do that anymore. So there is a real kind of conflict of interest in people who don't want to change their services structure or the content, because they will have to, for example, get rid of all the CBT people out of their ME CFS services. And as a psychologist, you know, there'd be more work for my colleagues if there was more CBT recommended. If there's less CBT recommended, there's less work for my colleagues. But I wouldn't say that that influences my interpretation of the research evidence. That's what NICE are doing. They're not caring about the entanglements. And then finally, embarrassment. There is a real cognitive dissonance problem here that accounts for much information in the modern world, where people find out that they're wrong, but that embarrasses them, that challenges them. It is very difficult for us to change our minds when it is shown that we are wrong. And that is a real thing in organisational change. And if you talk to psychologists who are trying to institute organisational change, it is past practice is often preserved precisely because people don't want to admit that something else is better or that what they were doing was wrong, was flawed. And that embarrassment factor is a real thing. And I think that is an interesting challenge ahead for implementation with these guidelines, because it's all very well to have guidelines written down on paper, but there's a whole psychology around getting people to change their attitudes around new guidelines when they're so invested in the old ones. But that doesn't mean it can't be done. And I'm sure, in fact, that it will be done. And with that, I'll just sign off with some further material and make this available to you after the talk, because we are in an interesting time, and we are at an interesting moment for ME CFS, and we are seeing change. And the myths are there, and you will encounter them. But the vast majority of people are kind of what we call floating voters. They don't have a prior assumption, and when they're presented with facts, they understand them and they deal with them and they act on them. When they're presented with myths, they can sometimes feel like facts. So I do think it's very important for activists and their supporters and allies to be vocal and to be assertive in presenting the factual information and in dispelling these myths, because the longer the myths pollute the discourse, the longer it will take us all to change direction. But I'm sure it will happen. I'm sure we will get it right. And I have every confidence that these myths will soon become a thing of the past. But with that, thank you very much for your time this evening.